Good morning. Welcome along, everybody, to In Control Scotland's. We should have coordinated it a bit better. Welcome along to In Control Scotland's monthly webinar Wednesday for August. I'm Pauline. I'm joined by Alastair.
Hello.
And today we are going to talk about, in quite a lot of detail, about a piece of research that we've just published on Option 2. How are we doing with Option 2 and individual service funds? And we'll be joined by the wonderful Lou Close, who is waiting in the wings to come and chat more.
Indeed. It's quite an exciting topic. And I think you were going to say, probably we're going to have a little bit of a think about simplifying it, so not jumping into too much jargon, just try to understand what Option 2 is first, because it can all be a bit daunting, can't it?
Aye, definitely. And we'll find out a wee bit more about that actually when Lou talks, but that's one of the biggest kind of things about Option 2 is it's a wee bit of a mystery sometimes, and people don't quite understand it or quite get what it really means. So definitely more on that later on this morning. But we've had a busy old month, haven't we, in the month of July?
We have indeed. So we've had a New Roots Home meeting, and we're going to have another one of those on the 1st of September. So the New Roots Home is about really taking up the challenge of the Coming Home report and supporting people to work proactively together on an individual and on a collective basis around about creating capacity for people to move out of hospital and avoid going in there in the first place. And so if you haven't already, please have a check out of our New Roots Home website and give us a shout, and anybody's welcome to join us. And we're particularly keen, I guess, we've had good engagement from third sector and from people with, family, individuals and families with lived experience, but we're particularly interested in growing sort of like social work, commissioning, health, anybody else to join as well, to try and get as much of that well-rounded, how we can tackle the challenges of kind of accepting the support and getting more options for people, but so that people don't just get fed up and give up and continue to stay in hospital.
Yeah, exactly. So great to see that. I think every time I've been along to New Roots Home, we've had somebody or more than one person join new for the first time. So word's getting out. So if you're involved, please share it. And if you're not and you want to find out more, like Alastair said, have a wee look at the website and you can find out all about New Roots Home.
Yeah.
But what else have we've also just opened up recruitment for our Working Together for Change programme, haven't we? Which is very exciting. So that's for people who are either using self-directed support or parents or carers for people using SDS, people working for providers, local authorities, health, anybody, advocacy, anybody who's interested and passionate about making a change in self-directed support in your community or nationally. And that's fully funded by the Scottish Government. Thank you for providing us with that funding to do that course. So there's a link to it on our website, isn't there, Alastair? Folk can find out more and apply.
Absolutely. So, I mean, again, it all fits with this. With one of our main factors is not just to talk about stuff and highlight it, but actually say, okay, so where's the gap? Where's the gap between where we are now and where do we need to be? And let's get our sleeves rolled up and let's crack on together and say, some of this stuff is tricky. If it wasn't tricky, folk would have done it by now. So let's work on it. So the good thing about the Working Together for Change, I think that everybody said, is that because it doesn't just target one group, it allows a lot of folk to come together and have a much more relaxed sort of like lead into that opportunity to explore difficult topics, and a bit longer to work on it as well. So we've got a couple of messages here. As you can tell, Keith's on the comments today.
Hi, Keith.
We've got Emma joining us as well. We'll share the Working Together for Change info with all the parents we work with. So that's brilliant. If you can share it far and wide, that's really helpful, because and I know that one of the things we've said is that sometimes people get anxious about something like this. What's expected of me? Is it going to be too hard for me? All that kind of stuff. And it's absolutely not. You can come and chat to us at any time. We're going to do a few frequently asked questions sort of videos But absolutely, if there's anything you're worried about the support, about the transport, about what's expected, absolutely get in touch with us. We're quite happy to chat it through.
Yeah, absolutely. And we'll be publishing more stuff on our social media and on our website for all of that. And Martin's saying that's what we need, multidisciplinary workshops. Nice to have you along, Martin. Thanks for joining us.
Yeah.
And that's absolutely the point, is that like we all have a wee bit of none of us individually have all the answers, but when we put all the people together, we all form all the different bits of the jigsaw and put it together, and we can see the problem and the solutions from all the different angles, and that's how real change happens.
Mm-hmm.
Very exciting.
And another thing that you spotted just recently was the Equality and Human Rights Commission have just come up with a bit of research. I might even be able to share the screen and show it. Let's see if we can. Self-directed support and personal outcomes. So
it was an interesting piece of research. It just landed in my inbox yesterday, so haven't had a read through of it. It speaks to people using self-directed support, people supporting people using self-directed support, and social workers as well, and talks about some of the positives, particularly around people who'd managed to achieve personal outcomes, but also some of the people who found it more difficult to use SDS to reach their outcomes. And quite a lot of it seems to come down, from my interpretation of it, to relationships and really good support planning and spending time at the earliest possible point in somebody's assessment and process going through SDS to really understand what the person wants to achieve and why it's important to them, and then how can you use the resources available to you to be able to do that. So it was an interesting read for me. We're definitely keen to speak with those folk and find out more and see how we can bring their experiences into what we do as well in Control Scotland.
Yeah, so definitely.
We could stick a link to that in the chat as well. Maybe afterwards. I'm not sure if you've got it there, but it's an interesting read for sure.
Yeah, definitely. So, and you can also download it from the Equality and Human Rights Commission website as well. Mm-hmm. So, yeah, here we go. Just what Alice said. So that's just Keith reminding us that just get in touch whatever way, whether it's by phone, by email, have a chat with us, and we are quite happy to talk about that. Mm-hmm. Other stuff that's been going on?
Well, a smooth segue on from good relationships and good support planning would be that our children and families lunchtime sessions are starting up after their summer break. We will be having that, when is it? The Thursday, the 25th of August at 12 o'clock. And that's going to look at new relationships and social work and social care. So really looking at relationship-based practice and how that's really the corner. Oh, there's smooth as. We've got the link to the EHRC website with the research. But if anybody is interested in self-directed support for children and families, you might be a parent or carer, you might be a young person, you might be working in social work, social care, any advocacy, whoever you are, you're welcome to come along and join us at the lunchtime sessions. They run the last Thursday of every month from 12 to 1:30, and send us a wee email if you want to get the link to that.
Perfect. And on a more social note as well, we've been folk related to the Stay Up Late campaign have been going along to the Doon the Rabbit Hole Festival in Stirling, and Michael McEwen had a blog about it, about his experiences, his first experiences as a disabled person, his first experience of being at a festival and what he thought it was like. So I think always there's stuff you can learn about how accessible was it, did it feel good? Did it, did you feel like a place? All that kind of stuff. So I'll have a check out of his blog on the National if you can. Mm-hmm. And we are still in the planning processes for a live Stay Up Late event later on this year, probably September, October, up in Aberdeen. And we're thinking of maybe combining it with the music at night, but combining it maybe with a bit of a discussion about some of the other important topics, earlier on. So a bit of fun stuff and a bit of chat about change as well, because we like to do that.
That's what we like. That's what we like to hear. And it sounded like they all had a great time, though. A fun-filled few days for sure. And nice as well for doing the rabbit hole to put on a wee talk at what they call the Duniversity, which is like the tent for people to have discussions and chats on the stage. So I believe some of the gang, including Keith from Stay Up Late Scotland, were lecturers at Duniversity, which is nice.
Brilliant. Do you get an honorary degree there for that?
I bet you Keith would have won a wee cap. I could see that happening. Final wee thing, I suppose, to plug before we go over to the main meat of today's conversation is about another piece of work that we're doing through our Scottish Government funded work, which is looking at what we're calling kind of the roads less travelled in self-directed support, and opening up conversations with folk working in services like addiction services, criminal justice services, homelessness services, places where SDS isn't particularly well embedded, and we'd like to do a bit of exploratory work. We'd like to get in and have a wee rummage about and see if we can understand what the barriers and the challenges are to making self-direction possible for people in a broader range of services. So going to be holding a few chats and conversations about that in the next wee month or so. So if you're interested, if you come from that bit of the world and you'd like to have a chat, please do get in touch, because I'd love to hear from you. We're just rummaging about and seeing what we can uncover just now. It'd be brilliant to hear from you.
Brilliant. Okay, well, we will welcome our guest on. Here is Lou Close. Hi, Lou.
Hi, good to be here.
Thank you so much for joining us. Do you want to just take a wee minute just to introduce yourself, Lou? Tell us who you are, where you come from.
Yeah, absolutely. So I'm Lou Close. I'm sure some people on the call will have come across me over the years. I've been around for a long time doing work around self-directed support and person-centered thinking and changing organisations to be better at what they do for many years. And I currently live in Kinlochhew, which is in the Highlands in Wester Ross. So that's been the last couple of years. Before that, I lived down in Cumbria and worked all over the UK, but pretty much working in Scotland now. And I've done bits and pieces for In Control Scotland or with In Control Scotland for quite a few years now. Most recently, I suppose, working with Alastair on the positive risk-taking stuff, risk in a real life and all of that, which was a really good thing to be involved in.
Excellent. Thank you so much for joining us today and for doing this fantastic piece of work. So before we really launch into the what the research found and what it was for, Lou, would you mind telling us, we were talked at the beginning about the kind of mystery surrounding option 2 of SDS and why sometimes it can feel a wee bit less understood than some of the other options in self-directed support. Could you tell us, just in plain and simple terms for us, what is option 2?
So option 2 is in between option 1 and 3, and it's meant to be quite different from the other two. That's probably the most important thing to say. Option 1 and option 3 both existed before the Self-Directed Support Act. They were kind of what we already did. So option 1 is direct payments. It's where the money comes out of a local authority or health and social care partnership and goes into the bank account of the person or the family using the service. Been around for 30 years nearly, kind of really well understood, really well used. Option 3 is what used to be the alternative to that, which was commissioned services that the local authority or health and social care partnership just got on with and delivered. And as a person using those services, you had potentially a really good experience if they were a really good service, or potentially not such a great experience if they were a really rubbish service. And that was basically your two choices: either get what you're given and like it or lump it and hope it's pretty good, or take full responsibility for the whole lot yourself and kind of get on with it. So option 2 was designed to be a bit of a midway ground between those two extremes, to give people the kind of choice and control that you got with direct payments without the direct responsibility for managing the budget, which is one of the things that quite often put people off using direct payments. So the theory was, and the definition from the Self-Directed Support Act is, that option 2 is where the money essentially comes out of the local authority and is managed and looked after by a third party, usually a provider. So it doesn't go directly to the person, it goes to a third party. So it comes away from the local authority, which means they don't have the choice and control, you do. but you don't have that same level of responsibility that you might have under direct payments.
So that sounds wonderful, and it's sometimes referred to as the best of both worlds, isn't it? And we call it that in the research report. So, but you would think with something that sounds like an absolute perfect middle between full choice and control and very little choice and control, that everybody would be taking this up, but it hasn't been taken up as much as we would have thought, has it?
No, not at all. And what we discovered, or what we felt, was that there are actually lots of examples out there. There are lots of case studies and examples of individuals and families who've done fantastic and wonderful things using option 2, or what we sometimes call it an individual service fund, an ISF. There's some really good examples out there of people that have done excellent things, but what we kind of felt was, or we wondered was, are they the exceptions rather than the rule? Are they the kind of I've worked in a lot of local authorities, and I've worked in a lot of provider agencies, and we used to have a saying that the squeaky wheel gets oiled. And I guess what I mean by that is, if you were if the situation was either really complex and difficult and unusual, or the person or family were really good self-advocates and shouted up a lot and said, no, this isn't good enough, then that situation might get resolved through a really creative and innovative process, and they might use option 2 for that. But what we kind of wondered was, but is it actually happening across the board for people, or is it just in those exceptional cases? So yeah, it's also been described as the missing piece of the jigsaw. Absolutely, yeah. I think that's a really good way of putting it. So what we wanted to do is we wanted to kind of find some areas, some regions across Scotland where it was more business as usual, where option 2 was regularly used, routinely used for people. And what we discovered was, yeah, it isn't really. Even in those areas where that came forward and that we've worked with 6 different areas over the past several months. Even those areas, when you look at the numbers, the percentages of people that are using option 2, they're really, really small compared to people that are on option 3, which is the vast majority in most cases, or that are using option 1, direct payment.
Mm-hmm. So really, I suppose the point of this research was to find out why. Why is that happening? Why is it not happening? Why? And what kind of percentages are we talking about here, Lou? Is it like 1%, 2%?
They're down in the kind of single figures. So we're talking about 4 and 6 and 7% of overall people that are using the service. So for every 100 people that are using services, 4 or 5 or 6 of them might be using an option 2. And that's pretty low, really. And that's the 6 local authorities that we've worked with who say and are, doing really good work around option 2. So it kind of makes you wonder what's happening in the ones that we haven't worked with, which could be doing loads, but chances are I think they're probably doing a lot less. Yeah, absolutely.
So that is one of the things, isn't it, that we've heard about self-directed support generally a lot of the time, isn't it, that individual responses are still too much driven by either the quality of the relationship or the skills and knowledge and confidence of the people who are describing it, or the ability to continue to ask the questions and to frame things in a certain way that will ensure that people come back to you. I mean, coming back to that risk in a real life that we did before, one of the points that we made in there was that we had to identify what the risk was of doing nothing or not doing the thing that was being asked for, and that to be equally as well recorded as the point of doing something that was being asked for, because quite often there'd be massive risks of not taking things forward, and a lot of the time we see that balance isn't really there, and that sometimes people are left without things for a long period of time. We've got another comment here from Jim. 9 years down the road, option 2 is not more mainstream. So why do you think this is? So that's Jim asking.
Well, That's jumping straight into the kind of report, really. So if we want to get into the kind of detail of it, I guess now's the time. Yeah.
Absolutely, yeah. So, like, I suppose as a first point, who did you speak to
Who
in
did
this?
we
Like,
work
when we're
with? Yeah. So we worked with 6 different areas. So we worked with Aberdeenshire, East Ayrshire, Edinburgh, Falkirk, Highland, and Scottish Borders. And those authorities, those 6 areas, were chosen by a combination of means. So we put out, In Control Scotland put out a request. Does anybody want to come and play with us on this? We also contacted people that we knew were already doing quite a lot of work on it. And we contacted our contacts in people like Healthcare Improvement Scotland and CCPS and people like that, Coalition of Care Providers Scotland, and said, who do you know that's doing a good job? And through a combination of those kind of conversations and contacts, we came up with these 6 authorities to work with. Within those 6 areas, we then spoke to the key people who are responsible for commissioning services and overseeing things like procurement. We talked to social workers and frontline workers who have a variety of different titles, but people who are basically working with individuals and families. We spoke to provider organisations who were working in those areas, and we spoke to the kind of third sector organisations that are supporting people, so that have got the support in the right direction, funding to provide information and advice and support around self-directed support. We also spoke to kind of finance people and IT and systems people within the health and social care partnerships. We deliberately didn't speak to people who use services and families because we really wanted to get to the nuts and bolts of how the individual service fund works behind the scenes. And most of the individuals and families that we've spoken to in the past are really able and articulate in talking about their experience of using an ISF, an individual service fund, but not necessarily, they wouldn't necessarily know what the systems and processes are that the local authority uses to support that. So we really wanted to focus in on those nuts and bolts. And what we did was we came up with 9 questions that we asked, and we asked those 9 questions of each of the 6 areas, so that we got that kind of consistency around making sure that we spoke to the same people about the same sorts of things. Do you want me to run through the 9 questions just briefly?
Yeah.
Would that be useful? Yeah. Okay. So the first question was the local definition, and that's where we immediately kind of fell flat on our faces because we kind of assumed that everybody was calling it the same thing, and they're not. And that links to our first recommendation, which is let's get a national definition of this thing so that everybody's starting from the same place. So the national definition that comes from the SDS Scotland Act is really simply that an option 2 is funding allocated to a provider of choice or other third party. That's what it says in the legislation. The definitions across our 6 local authorities were quite different. Some were very similar to that, others were quite different to that. And so obviously, when those local authorities are then working with individuals and families, they're working from the starting point of their local definition rather than the national definition. So it's immediately obvious why things start going in different directions, I think. And a lot of those definitions included the words like a provider of choice, another third party, or the local authority. So they and even with the local authority at the beginning. So immediately there's a kind of expectation built in that it may still be that the money is retained and looked after and managed by the local authority, which makes you kind of wonder, so what's different? If you're starting from a perspective where the local authority can carry on holding the budget, what's different about that from option 3, basically? We then looked at numbers, so how many people have actually been using option 2 or individual service funds in each area, and we broke those numbers down. In most of the areas we were able to break those down, or they were able to break those down by what we would call client groups. So how many people of that kind of 6 or 7%, how many people of those were people with learning disabilities, with mental health issues, with older people with physical disabilities, etc., etc. So we're able to look at that a little bit more, and that's all detailed in the report. We got some examples. We got lots of examples from people. So where are you, what are you using option 2 for? Give us some examples of how it's different to option 3 and option 1. And we got lots of different examples, as you would imagine, of really exciting and wonderful things that people are doing, and that's great. But what we then went on to find out about was kind of what's the wider commissioning approach that goes around option 2. And what we discovered is option 2 is often a bit arbitrary. So what I mean by that is it's logged as an option 2. The Health and Social Care Partnership record it as being option 2, basically because the person said, oh, I quite like that provider. And that therefore is kind of ticking a box saying, well, they chose. But not in all cases does the person then actually go on to do the work with the providers. Sometimes the social worker and the commissioning officer still dictate kind of how the package works out, which kind of feels a lot like option 3, really. What we also heard a lot of people saying was people spoke about things not being in the spirit of the Act. So it's kind of, it's option 2, but it's not really in the spirit of the Act, which was quite useful. Aberdeenshire has now closed all elderly day centres for good. Option 3 was this report before that decision. I'm not aware of that, Martin. I'm not aware of that part of the process up in Aberdeenshire, I'm afraid. So I don't know how it's related or not. But something to kind of dig into, I guess. I suppose the other thing about the keywords of provider of choice, absolutely. And what we also found was that when I use the term arbitrary, sometimes option 2 is what's chosen, using my little air quotes there, by the person because it's the only option. So there were a number of examples given where somebody had an assessed care need, care and support need, and there isn't an option 3, probably similar to what's just been put up there. There's no daycare provision because they've all been closed. So there isn't an option 3. Option 1 or direct payments aren't available for whatever variety of reasons. It may be that the person doesn't want to or isn't able to manage an option 1 direct payment, nobody else is, or that there simply aren't any organisations or people out there to pay to do the work, even if you could manage a direct payment. So option 2 kind of becomes the default option. And again, that's not really a proactive choice or showing control to people. So it was really interesting to kind of dig into all of that. And what we discovered as well in terms of the wider commissioning approach was that there's quite a lot of difference, and people, a lot of areas are still using frameworks. Some areas had frameworks for, so like an approved provider list for option 2, as well as for option 3, which kind of feels a bit or a lot restrictive to say, well, you can have this option 2, which is lots of choice and control, but actually you can only choose from these people that we've already decided are kind of okay. And that kind of links back to what Alastair was saying really about risk, and risk came up a lot. The area's appetite for risk really dictates how far they go. Really classic example was that came up and is dug into a little bit more in the report, is using option 2 to employ self-employed workers. And some of the areas that we spoke to said, yeah, absolutely no problem, don't have an issue with that. We give people a little bit of guidance and, off they go. Others were saying, no, our legal department say it absolutely isn't acceptable, we can't do it, won't do it, whether it's option 2 or option 1 even. So real difference across just 6 different health and social care partnerships in Scotland, which again begs the question, what about the rest? What about the other 20, 26 or whatever it is? So we also, other questions that we asked about how option 2 is managed in terms of brokerage or a similar type function. Aberdeenshire, it's already been mentioned. Aberdeenshire is one of the places that uses, I guess, what we might in Control Scotland consider to be the model approach for an option 2 or a self-directed, an individual service fund. And that is that the budgets are all handled by one organisation, and Cornerstone in this case, who don't provide services to people under option 2, but they do hold the budget and manage it for them. And Aberdeenshire have got a really clear contract with Cornerstone. It's been in the making for about 5 years, and it's continuing to be a bit of a work in progress. But that is a really clear situation. If you choose option 2, we will give the money to Cornerstone, and Cornerstone will help you and work with you as the individual or family concerned to work with providers and other organisations, buy what you need, spend the money in the ways that make sense to you and your support plan.
So just thinking about some of the points that you've raised there, and just going into them a bit more. One of the things, obviously, one of the challenges when you're trying to do a bit of work like this is to get people to talk to you, because there's an anxiety when everybody's doing it different and nobody's really got it sussed. That, you know, that when you start sharing, that people are going to start saying, well, that's not good enough. But I guess the whole thing about In Control Scotland and our approach is about share. It should be a safe space. We are going to challenge and we're going to push for better, but we'll do it together. It's not about blame. And I think that one of the things that you've identified there is that if we can share those good examples of things where the sky hasn't fallen in, despite, you know, using, you know, things like, you know, self-employed workers. I mean, I've helped to set up a cooperative in the northeast of Scotland, and the original answer in the northeast was, we are just not using them because, you know, there's, you know, it could be dodgy. How do we check? We asked what checks people wanted. We set them up, and now there's a lack of people to provide it. You know, the people have been so happy with the services. So that's an example. I think one of the other things that's quite interesting that I picked up from your findings was there are some actual active disincentives that are set up by some of the systems, and we've identified this before with things like option 1. You know, this idea of hours. If everything's just done in hours and you're entitled to a different hourly rate for option 1, 2, and 3, then the issue is that you know, you can get more service from option 3 because it's the same number of hours, and that doesn't make any sense. And that's because the whole idea is you get an amount of resource and you make the best use of it. It's not like, it's a bit like saying you can have 10 items from Marks and Spencer's, you can have 10 items from Lidl's. You know what I mean? It just doesn't make sense. You know. Just wondered if you wanted to say anything more about that.
And we talked in each area about cost and about whether there was a kind of management cost attached to people using option 2 or an individual service fund. Exactly that, Alastair. And you know, in some areas that was one of the things that was a bit of a barrier, because there was no facility necessarily to pay an additional charge. Other areas where the provider comes along and says, yeah, we need a bit of extra money to manage this. It's kind of built into their hourly rate. So it was a bit of a fudge in some areas. In other areas, it's kind of like, yeah, well, this is accepted. And obviously in the Aberdeenshire example, that contract has been given to Cornerstone, so they get paid to do the work. And then that doesn't come out of the individual's personal budget in the same way. That's you know, what you would call a service level agreement contract with Cornerstone. So that's quite different. But yeah, there's subtleties around that. I think that really do make a difference to people. And you know, there are some areas where the hourly rate is different if it's option 3 or option 1 or option 2, and obviously that is a baked in disincentive. But we're talking about hourly rates here. So user experience of Cornerstone, not so nice to be polite, right? Okay. I guess there's good, bad, and indifferent in all situations, isn't there? Yeah, I mean, I'm certainly, you know, I'm talking about the situation that we discovered that was, if you dig into the report, there, you know, there's mixed experiences. It's definitely a work in progress up there, but it's a good model, and we think it's a good model anyway. I've lost my thread there slightly, talking about costs and things, but we also asked a bit about option 4. Where is option 4 at in areas, because we're kind of assuming that if people are using option 4, some of those would include an option 2. And option 4 is kind of, it felt like a bit, again, in terms of how it's recorded, it felt a bit like a bit of a mixed bag. But there were examples where people use option 4. Option 4 is a mixture of the other options. And there were examples where people use option 4 where it's a combination of a commissioned service and a direct payment, or a commissioned service and an ISF. So there was quite a few of those to kind of look at. What we spoke about then to people were specifically what were the key things that needed to happen in order for them in their area to change, in order for them to make albeit a relatively small number, but to make option 2 much more widely available to people. What were the things that they needed to do and to have in place in order to make that change? And one of the things we had a separate question about, but which came up quite a lot under that discussion, was leadership. Was that if you've got really clear from the top of the organisation leaders cited on choice and control and pushing and driving the agenda, then it works and it starts to happen. Where you've got senior leaders or leaders further down the kind of chain of command that aren't cited on it, it tends to happen a lot less. And one social work practitioner that I spoke to actually said, you know, if your manager's not asking you how many option 2s you've got, then you're not going to focus on pushing your option 2 numbers up. And you know, that's kind of obvious, I guess, to many of us. The things that people came up with in terms of things that were really important, key kind of levers of change. So leadership was one of them. Having really good training and not just going, oh yeah, we did our SDS training 10 years ago when the Act came out, so you know we're sorted. Having SDS training ongoing, having training, and this is for staff within health and social care partnerships, as well as providers, third sector organisations, and crucially people who use services and family carers and the organisations that support them, so that people understand, well, what actually is this thing that I'm being offered, and can therefore choose it more openly. People talked about having training specifically around option 2 being really helpful, so pulling it out of the overall SDS training and talking about option 2 specifically. And certainly in the areas that we worked with, that is something that happens, which perhaps is linked to why they're further forward in doing some of this work than other areas. People talked about having good partnership organisations, so the third sector organisations that do the information and advice, which is really important, and also having an open approach to commissioning in general, I think, which is really important. And just going back onto that point, really, we've mentioned hourly rates. That's where I went off. I lost my thread slightly. We were talking about hourly rates and cost. And hourly rates is definitely one of the things that is really restricting the application of option 2, because every authority that we work with still very much works with an hourly rate as a unit of time, as a unit of money in terms of the budget. And it works if you're paying for somebody's time, but it doesn't work if you're paying for something else. And that's, you know, it's become a bit of a blunt instrument.
And what we mean, oh, sorry. I was just going to clarify that a wee bit. What we mean by that is when somebody goes through their initial assessment, it can be in terms of lots and lots of things that are nothing to do with units of time. But at the end, if your final budget or your final support plan spits out a number of hours, then it's really difficult to think about using that budget for anything other than a number of hours like that. So it's a fundamental issue in how assessment and allocation systems are kind of developed and designed, that if you spit out a number of hours at the end, it's really tricky to think about anything other than what that might look like in terms of a number of hours.
Exactly.
Yeah, I mean, I've had experience of somebody losing a service that was a respite service, which was not listed as part of their budget. So it wasn't counted. It was like, oh, well, that's not part of your budget. I said, but it's not free, is it? So you know what I mean? Some of the ways that we just categorize things, and the same person asking for tech support, you know, fairly cheap but technical stuff that would help improve, reduce anxiety and improve their confidence for going about and out and about different places, and being turned down because that wasn't what was put in the assessment. But the assessment was overall mental health and well-being. And although, you know, so it's that thing, if we don't get right at the start, we end up just pushing ourselves down the idea that this is something different, when it's not. If we start with a really good assessment that focuses on outcomes, then there should be much less. And I think that's one of the things that you really focus in on is the autonomy, the need for people to back off and let the people who know best and who are most connected to say, if it's within the budget and it meets the outcomes, let folk crack on, because that's been proven to have really good results.
Definitely. And where we saw examples of option 2 working really well, people were able, the support plan that had been agreed with the individual was wide enough in terms of outcomes for them to be able to flex and change. So examples that were given were where the support plan says, you know, that there's an outcome around healthy living, that somebody wants to you know, use part of their personal budget individual service fund to get more healthy, or remain healthy. Even though they began by using the money to perhaps pay for a gym membership, when that didn't work out for whatever reason, or one example was given during COVID, the gyms were all closed, the person could just say, right, okay, well, instead of using that money for that, I'll buy myself a treadmill, or a you know, a static bicycle for my house or something like that. Now, in areas where the support plan was more prescriptive and had actually said gym membership, the person had to go back via the social worker to get that change agreed. But where the support plan was wide enough and had the outcomes at the focus, they were able to flex and just spend the money. And that really is what option 2 should be about. It should be about the individual and the provider saying, right, okay, well, we said we were going to use the money for this, but it isn't working out for whatever reason. What else could we do with that amount of money that would meet that outcome? And there's lots of examples of that. So again, the support, and our second recommendation is about exactly that. It's about support plans being properly person-centred and outcomes focused, and not being you know, reduced down to a number of hours. Too many social workers feel like they're on a treadmill already. Yeah, I mean, the social workers that I spoke to, you know, some of the social workers that I spoke to were so passionate about option 2 and so passionate about pushing it for people, because they can see, and Pauline, you said this right at the beginning, it's the best of both worlds. It is the right fit for so many people where the commissioned services just aren't okay for them. They're not what they need, and they don't, or you know, they don't want or aren't able to manage a direct payment. Option 2 is the perfect, you know, the mix, the best of both worlds. So yeah, we had our third recommendation was around, and this is kind of again picking up on what we've just been talking about, around making it easier for support providers to manage option 2 budgets for people. And again, we got a really wide range of comments when I spoke to providers. Some of the providers were massive fans of option 2 of individual service funds. I actually spoke to one who said the first experience of using an individual service fund was such a revelation in terms of how much more freedom they had to work properly, as she put it, with the people they supported, that they're proactively disentangling themselves from their option 3 contract with the local authority. And whenever a new person comes through, they're saying, no, we'll only take this on as an individual service fund. And when I said, well, what is it about the option 3 contract that's different, that you don't like? And she said, it's time and task focused. It's not about outcomes, it's not about the individual, it's time and task focused when we've got an option 3 commissioned service. What do you think? Why do you think we're still stuck on hourly rates rather than individual service fund means we need? Well, that's the $64,000 question, isn't it? And we have a recommendation which says this needs to be looked at a national level. We need to actually do a piece of work nationally to say, you know, we've got to get back to that idea of an upfront allocation of resource that is then used by the person to meet their outcomes, not kind of directed into a number of hours before they even start thinking about what they're going to do with it. That's one of our key recommendations, because it's got to change, and looking at the whole kind of commissioning process around it, I guess. I think I've probably covered. Let me just check which. I'll just have a look. I've got my easy read version of the report up here on my other screen, which is much easier than going through 52 pages.
52 pages. I know. So just while you're looking that up, we'll just remind folks, so you can download both of those versions, both the easy read and the full version, from In Control Scotland's website. And then we're going to be having another follow-up discussion on this on our lunchtime session on the 9th. Because I mean, we've got, like Jim's asking, how do we play a part in this? So I guess that's
yeah.
We're keen to keep this conversation going. So that lunchtime session on the 9th, we'll be having a sort of like another hour on this. So again, anybody's free to join us if they want to be part of that.
If you want to join in, sorry. I was just going to say, if you want to join in that, send me an email to info@in-controlscotland.org.uk and we'll send you the link. So please come along. It should be a good discussion. Sorry, Lou, go for it.
No, that's okay. The one that I've missed, I think, in terms of the recommendations is that there should be an agreement at a national level as to whether or not health and social care partnerships can hold budgets around under option 2, or whether it really does need to go back to that original definition and say it's a third party or provider that holds the budget, because there are examples. I mean, some of our areas, the money stays kind of ring fenced within the local authority, but the provider's paid, kind of full weekly in advance, and they have complete control with the individual about what they can do, and they flex and do things like I've just described, buy a bike instead of going to the gym or whatever, without having to go back to the social worker. So in a sense, in those areas, the fact that the money hasn't come out to the provider in what we would necessarily consider to be an option 2 doesn't really make any difference. They're still getting that choice and control. But in other areas, it's the very fact that the money's left the local authority in a different way and gone to the provider to actually hold an account for retrospectively, that makes the difference for people. So there's a recommendation around that. And then the last recommendation, because we talked a bit about the one around commissioning and hourly rates and frameworks and stuff like that, getting away from all that kind of thing. The last recommendation is around worker autonomy. So what we mean by that is that individual social work practitioners and social care practitioners are trusted to do the right thing and not to have to keep checking back with managers and things like this. And certainly, as you would be unsurprised to hear, where those folk within the health and social care partnership felt they were trusted, there was an obvious kind of link to how much more choice and control the people they support have over their care and support. So if somebody feels they've got to continually go back and check with a manager who then goes back and checks with another manager, then it kind of diminishes the amount of choice and control that the person has. And again, quite different in different areas. I spoke to some practitioners who felt, if I tell my manager that I've done something, they're completely happy with that. I spoke to one of the other areas that was quite interesting was speaking to finance and kind of people from what you might call the back office, and there was a really marked difference in some areas where the finance team, in the areas where option 2 is really working well, the finance team's attitude was, well, it's not my job to say what people can or can't spend the money on. That's nothing to do with me. My job is to make the budget balance. And if the social worker and the person have agreed that they can spend the money on, I don't know, something, that's fine. It's nothing to do with me. I don't have an opinion in this. I'm the finance person. I count fees. In other areas, we did actually, one area that I spoke to was talking about finance people actually being brought into planning meetings, and that they were really, really concerned about that, because that gives a really skewed kind of message to individuals, that we've got somebody from the finance team sitting here when we're just talking about your support plan. That feels, like the wrong way to go. So those, again, two kind of extremes and everything in between. Just another kind of final point around the recommendation about kind of commissioning. There's a bit in it that talks about helping providers to proactively develop the systems they need to manage an option 2. So Edinburgh, for example, they've got 32 providers that are on their framework for option 2, but none of them had actually done anything other than sign up to the framework. So what I heard when I spoke to the providers was, the first time you actually get asked to do one, it's a really clunky, laborious process, because we've got to figure it out with that first one. Whereas once they'd got it in place, then the second one and the third one and the fourth one came through, and it all worked beautifully. So there's something about kind of getting all your ducks in a row, getting everything set up first with the provider or as a provider, so that when you get asked to do an individual service fund, you know what you're doing and you can pick it up and run with it. And again, I think there's more work that needs to be done around that.
Mm-hmm. And speaking of more work to be done, since we're rapidly running out of time, this has been such an interesting chat. But we obviously started developing this research to be able to provide stuff that would be actually valuable to practitioners and organisations, and for them to learn from what's good and what's positive and possible around option 2, but also to think about the shared kind of challenges that folk might have and be struggling to overcome. So we're really keen that this isn't just a bit of research that sits on a shelf and gathers dust, that we go out and actually help to enrich the practice and develop the practice and health and social care partnerships to be able to share the good stuff and overcome the bad stuff. So what do you think happens next, Lou?
So in terms of next steps, we're planning what we're calling a deeper dive with a number of the partnerships that we've been working with, to actually, because they've basically, every single one of the areas that we've worked with have been so open and honest and, you know, willing to work with us. It's been brilliant, and given that we've discovered stuff that is good, bad and ugly within all of them, you know, lots of good stuff, I have to say, but also some kind of tricky bits and difficult bits. They've been really open about sharing some of their challenges, and all of them are really keen to do more work, to say, well, okay, we want our numbers to go up. We don't want it to be 7 or 8 or 9%. We want it to be, you know, 20 or 30%. You know, I mean, in theory, you've got 3 options. You should have at least 33% of people using each of them, arguably. So, you know, there's a need to do more work. And a couple of the areas we're working with, we're talking at the moment about doing some really concentrated work with them around the particularly sticky issues that came up for them as a part of this research. So that's about to start. And we're also obviously working with the National Collaboration Group, which I've got a meeting with this afternoon, to talk about you know, how we can start leveraging some of this stuff at a national level, how we can start influencing people to have some of these conversations nationally, because it's always the case that when a national kind of a national decision is made, our 32 health and social care partnerships all go, right, okay, that's what they said nationally, now well, we're going to make that look like locally. And sometimes that's really useful, because you know, I live in Highland and it's very different from Edinburgh in terms of the reality on the ground. So some of that is really useful and important. It can't be the same everywhere. And I think sometimes it's really not helpful where the kind of definition starts to shift, or, you know, things like you know, what's nationally recognised in terms of whether or not health and social care partnerships can or can't or should or shouldn't hold the budget for an option 2. You know, that ought to be decided at a national level, I think, rather than by each different partnership. So because otherwise you end up with a postcode lottery. There was a comment came up there about it changes within 5 miles in Aberdeenshire, and yeah, I mean, Edinburgh, again, just to mention Edinburgh, they're such a big, I mean, they're quite small geographically, but they're massive in terms of population, and they're divided into 4 different localities, and the 4 different localities do it differently. You know, and that's within one city. So yeah, some of these things, some of it's about responding, you know, reasonably to what's on the ground, but some of it's about actually saying, no, these are our national standards and this is what you should all be working within, parameters wise. So yeah, a lot more work to do, I think.
Brilliant. We'll look forward to chatting more about that on the 9th, and hearing about the next deeper dive. And I think, like always, if we just keep the channels open and people want to share their stories of good stuff and stuff that anything that they've learned and anything particularly that they've changed, whether they're part of this six key areas or not, is really helpful, because I think when people do share how they've moved forward with some of these things, that's where we get confidence to do things differently, rather than something went wrong once, so we just shut it down so it never happens again.
Yeah,
that's the stuff that tends to just destroy all the chances for creative work, which I think is what Keith said in one of his earlier comments. So.
Mm-hmm. Well, thank you so much, Lou, for taking time to come and speak to us about this morning. We could have spent another 3 hours chatting about this because it's so interesting. But just to reiterate, come along Tuesday next week at 12 o'clock. We'll be having that interactive session. If you want to join, send us an email or get in touch via the website. Hope to see you all there, as many of you as possible, and hopefully to get to speak to lots of you more about your experiences of option 2 and how we can make them better and make it more widely implemented. So we have run out of time. So just a big thank you to Lou and Alastair. And for all the questions and the conversations in the chat to come through, which is brilliant, we will be, and there's a wee reminder, Tuesday the 9th at 12 o'clock, come and join us for a more interactive discussion where you get to ask Lou lots of questions. And
absolutely.
And we'll see you for our next webinar Wednesday in September, believe it or not.
I know. Wow.
Right,
Cheers then.
right, see you all. Bye. Thank you.
Bye. Bye-bye.